Okay, we are recording now. For anyone who doesn't know me, my name is Christina Clark O'Karmas. I use she, her pronouns. I'm the executive director at the Alabama Campaign for Adolescent Sexual Health. We are the only organization in the state of Alabama that is working to advance comprehensive sex ed. We are also a statewide organization, so we have 3 full-time staff members. I am in Montgomery, and then you'll see a couple other staff members in the participant list. We have Brittany Winston, who is our lead health educator. She's up in Huntsville. And we have our health educator, Megan Lyle, who is in Birmingham. And so we are excited to be throughout the state and to be able to provide this information to y'all, and also to provide some direct programming to youth across the state. So I just want to highlight a couple of those we have coming up. If you know of any youth in Montgomery that are looking for a sex education curriculum that is specifically inclusive of LGBTQ students, we have one coming up on July 8th with Montgomery Pride United. We have another one happening in Birmingham on July 24th. So if you know of any young people ages 14 to 24 in Birmingham. And then we have one also in Mobile on August 10th. So if you know of any young people in Mobile, I will copy all those into the chat so that y'all can register your youth or share it with youth that you may know. Again, ages 14 to 24. Now, without any further ado, I'm going to introduce our speaker for today. Dr. Pamela Foster is a preventative medicine and public health physician who teaches in the community and rural department at the University of Alabama. Her current research is focused on HIV and AIDS related stigma in rural African American communities in Alabama, particularly in faith-based settings. Today's presentation will be on both faith-based approaches to sex ed and increasing accessibility and information about PrEP for women. So I will turn it over to you, Dr. Foster.
Surely. And I'm going to share my screen, and let's see if I can find my presentation.
And let me know if I need to make you a co-host.
I think,
or you may.
It looks like it's sharing, isn't it?
Yeah, it's sharing. So you're
sharing. Let me just need to move this thing out the way in order to make it big. Wait a minute. There we go. Slideshow. So welcome everyone. I just thought about something. Can you hear me? Can you see me?
Yep.
For some reason I fell off the screen. But anyway, I did do a project actually specifically around sexual education in Lowndes County. So I was looking for the report. It was called Project Wise. As soon as I can, when I finish up, I'll see if I can find it, put it in the chat, or either email it to you after the presentation, Christina, if people are interested.
That would be great. Yep.
What we did was we picked Lowndes County because it per capita, it at one point had the highest HIV rate. And we know sex education is a piece of that, especially in young people. So we wanted to try to kind of assess what kind of programs were going on in the county around sexual education. Where do young people get their sex education? So it's pretty interesting. And actually the recommendations that the community gave were really, really good recommendations that we generally don't think about in public health around where to have sex education training. They really keyed in on foster care, which we often forget, leave out. And they also talked about drug abuse programs, which we often leave out as well. So anyway, I'll get that report to you. This is a timely sort of presentation today. I added innovative strategies because I'm going to talk a little bit about media as well. But 2 emails I got today sort of talk about how timely these issues are. I got an email from ADPH about syphilis in prisons. There's a tick right now. I don't know if you knew about it, Christina, or others on the call.
Not aware, no.
Yes. So they're asking different organizations to come in and help them do testing. I think they're just going to do testing across the board in all the prisons, yeah, in Alabama. And that is not surprising. We've always had syphilis, as high rates of syphilis here in Alabama, and other STIs. But before I begin to, I wrote down the name Dr. Leah Yerby. I don't know if y'all remember, Dr. Yerby was on your board a while ago. She's one of my colleagues here, so I just wanted to give a shout out to
Oh,
her. Do you
okay.
remember
That
her,
must have been
Christina?
before my time.
It
That
was
and
it was probably a while ago.
okay, yeah,
Her,
must have been a while ago
yeah,
because I've been
her and Dr. Jim Leeper.
okay.
Uh,
No, I
oh,
wasn't aware of that.
long, yeah. And I've been here 18, 19 years, so it's been a minute since they were on
Okay.
board. Yeah,
Okay. Yeah.
yeah,
Yeah.
yeah.
Okay. Great. Well, that's great. Thank you so much for
Yes,
sharing
yes.
that.
So that was interesting because I got another email from NMAC, National Minority AIDS Coalition, really talking about a new, I'm going to talk about PrEP, of course, pre-prophylaxis. It's our, number one primary prevention tool for HIV now. We don't have a vaccine. Of course, we were always trying to look for a vaccine, but PrEP is our a great tool. Not great uptake in women, and especially women of color. So we'll talk a little bit about that. But there's a new treatment that's just come out by CDC called PrEP.
Okay.
And so that is post-exposure prophylaxis. You can give it up to 72 hours after exposure. Doxycycline, we know, is a very low-cost drug, so they're really recommending it as a treatment modality now for STIs. It was chlamydia. It was quite a few sexually transmitted infections, including syphilis. So I just wanted to kind of give a shout out about those two sort of new things that I just got in the email today.
Great. And that
So
doxypep would be for
doxypep
bacterial
would be for
infection.
sexually transmitted infections, not HIV,
Right.
but others like syphilis. Let me give you the list here.
Chlamydia,
Probably all
gonorrhea.
the bacterial ones, so syphilis,
Correct. All the bacterial ones.
chlamydia,
Correct. Correct.
gonorrhea.
Correct.
Okay.
I think chlamydia is in the list. It has here specifically syphilis, chlamydia, and gonorrhea
Yeah.
among men and transgender women. They really want to
Pushing it on those
target
populations.
those women. Yes.
Okay.
So
Okay.
so that and I guess the take home message is so low cost, is so available, that it would be a good modality to kind of think about. I guess the other there's always something going on. We have to sort of keep up in the field
Yeah.
constantly. I'm going to talk about a radio show I do for that's targeting Black women in Montgomery. But our show we just did, which is airing this week, is about vampire facials. Has anybody heard of that? Vampire facials? Anybody?
Goodness. No.
No,
I'm scared to.
I'd never heard of it either. It was made popular by Kim Kardashian. Leave it up to Kim, the Kardashians, right? It's what they call a medical spa sort of
Okay.
treatment. It is multi injections. What they do is they take the person's blood, they separate the blood and separate out the plasma, plasma rich, platelet rich plasmas, the platelets in the plasma, and they inject it back into the skin, usually the face, but other parts of the body as well, but multiple hundreds of just injections. And what they found was because, there's blood involved, they found some new cases of HIV in 4 women in New
Wow.
Mexico. Yes. So new form of transmission that we have to pay attention to. I had never even heard of this facial.
Wow.
Similar to, in the same vein as Botox, of
Yeah.
course, but
Yeah.
you give it much, much more. If you look at a picture that they had of Kim Kardashian, it's really hundreds. It looks like hundreds of bites on her face, bloody. of course, the spa that it was done at in New Mexico was not a licensed provider.
Okay.
Just take home lesson number 2. A lot of people are getting these surgeries, medical spa surgeries, butt implants, other things, not by licensed providers and not by providers that are using appropriate infection control measures. So that's
Sure.
the other take home message. That's how the HIV was transmitted in this setting. So just always something new to keep in mind, right? As we think about treatment. So as I said, I'm just going to talk a little bit about HIV in women. I'm going to give you talk a little bit about the show I do called A Woman's Worth. Then a little bit about faith, my faith-based project called Project Faith, and then we'll talk a little bit about PrEP uptake in women. Please stop me. I'm very informal, so anytime you have a question, please feel free to ask questions. Anybody have a question on anything I've said so far? Nope. Okay, we'll keep going. So when it comes to HIV, women are often ignored. And I'm asking the question now, why do you think that's so? You can take yourself off mute and just answer the question.
Yeah, if I put you on mute, it was only because to eliminate the background noise. So feel free
Right,
to
right. How
bring
about
yourself
taking
up.
them off just for a second and just answer this? I want a little participation. Can you take them off?
Maybe because there's more of a stigma related to people who identify as LGBTQ plus, especially gay men with HIV.
Could be that. And maybe because, when the HIV first came on the scene in the 80s, 1980s, some of you might not have been born. It was mainly in men, remember? Here in this country, it was primarily in men. The evolution of HIV in this country in women evolved. But remember at the same time that there were hardly not that many cases here in the US. There were lots of cases of women in sub-Saharan Africa. So, but some of it is because just didn't really recognize that it affected women initially here in this country. Any other reasons why?
Maybe because women aren't considered, as I don't want to say I'm valuable, but some men or providers may not think that women are as valuable as men.
That's interesting. Yes. And I think also not as high risk. The numbers, I'm going to show you the numbers. Most of the numbers are in men. I mean, 2/3 of cases of HIV are in men having sex with men. And now that's Black men and Latina men are also up there. It used to be white men, but the demographics have changed. So the cases in women are not as high as men, but we do have women who have HIV. So that's not a reason to ignore it. So, but your point about the value of women, maybe, and some of it is also, even when we're going to talk about PrEP, PrEP is, is a valuable tool, primary prevention tool, the best that we have, but the uptake in certain populations is lower. So the uptake in white gay men is high, and the uptake in women, for example, is low. And the uptake in communities of color is low. Why do you think that's the case?
I would imagine, I mean, maybe this, I don't know how true this would be for women, but in communities of color, there might be still some distrust of medical providers because of the long history.
Definitely have to factor that in. But some of it has to do with advertising. I mean, when PrEP first came out, it was advertised mainly in white gay men. We didn't see the pictures of women. They didn't advertise the women at all. We didn't see pictures of communities of color. Now, if you're looking now at PrEP, we're seeing PrEP on TV, right? You're seeing a little bit more diversity around there. So at a glance, let's start with the statistics. Although there are no significant changes in the estimated new cases of infections among women in the US overall from 2015 to 2019, the annual number is going in the right direction. So the numbers are decreasing, but they're still much lower than men's. See here, 6,800 to 6,400. And I think I have a slide in the next one that shows you the cases in men are much, much higher, smaller numbers of new cases in women. So 34,800,000 estimated new infections in the US in 2019, only 20% were among women. Okay, so we have smaller numbers and we're trying to decrease those numbers, but it's still not a reason to ignore women. And as we know, there are inequalities, health disparities within HIV. Right now in 2024, it definitely affects more groups than others. And, you know, some of it has to do with social and structural issues like HIV stigma, homophobia, discrimination, poverty, limited access to high quality care can all influence health outcomes. But it's interesting, they don't have in here that distrust that somebody said about a big factor as well for why there might be health inequalities in different groups. But Black women are definitely much more affected. They continue to be disproportionately affected by HIV. Out of the 6,400 cases, 64% are Black. Of the 6,400 cases of women who are HIV positives, more than 54% are Black, more than half are Black. You see 22% for white and 19% Latino, Hispanic, or emerging. Numbers that we're looking at closely, but the other groups are relatively small: Asian, American Indian, Asian Pacific Islander, others. So definitely groups we really have to pay attention to are Black and Latina. And most of the new cases of HIV in women are definitely attributed to heterosexual contact. At one point, you know, injection drug use was a major issue, specifically in certain cities, but not just in cities. We've got a drug issue here in Alabama as well. And some of the rural areas we're seeing increasing numbers, but still heterosexual contact is the main category. And that's why, you know, paying attention to the STIs as well is so important. And what your group does is so important, really, for really addressing this issue.
Thanks.
I said,
we're
go
trying
ahead.
our best.
Yes. Yeah, I know you are. And lots of work to be done, I'm sure.
Yes.
Yes. Primary prevention tools for HIV, of course, abstinence, which is unrealistic, in the work you do. By the time, I guess, is the number still around 2/3 of high school students will be sexually active by the time they leave high school?
It's a little bit less than that.
Okay.
The most recent CDC data showed right around 40-ish%.
Okay.
So maybe it's dropped a bit, but
Okay.
Of those that have, then they're not using a lot of protection.
Right.
Yeah.
So if you have people that are abstinence from sexual and drug activity, but that's behavioral, so not easy to control. Needle exchange programs work. We don't have a lot of them here in Alabama because of the Bible Belt, just much more conservative. Even the bleaching, the paraphernalia, that kind of thing as well. Barrier methods do work when used consistently and correctly. And I'm sure you have horror stories like I've heard of, people putting Vaseline on condoms, people putting Crisco oil.
Oh.
on
gosh.
condoms and not using them correctly, not knowing how to use them, not
Right.
reading the instructions that would help.
Yeah.
You know, back in the day, the white gay community, white male gay community actually had demonstrations
Mm,
on how to use a condom correctly, and that helped.
yeah.
I haven't seen that lately, you know, on the banana. Those
Yeah.
kinds of
A lot of
things.
what we find is that, a lot of places where we might be able to work with young people, like a school, for example,
Mhm.
just there's absolutely no interest in. If you can even get in with a sex ed curricula, there's,
Yes.
most of them are
So,
not gonna let
so
you do
with
a
that
condom
Lowndes County,
demonstration.
what it was interesting in Lowndes County, you know, we worked with the superintendent. There are counties where the school systems are very concerned
Mm,
and are interested. Of course, they've got to deal with parents, but
right.
even if they can get permission, you know, they will allow some education. So that was part of our report as well.
Yeah.
School is the obvious choice, but we looked at venues outside of school, like after school programs, community-based organizations within the community were open, and believe it or not, the church. Some of the church pastors really understood the value of it, and really kind of targeting churches might not be a bad idea.
Yeah.
But
And I am eager to
yes,
hear from you about that
yes,
experience for
yes, yes.
sure.
So but PrEP is our best tool, pre-exposure prophylaxis analogous. You know, we don't have a vaccine, so it's really our tool to prevent persons from getting HIV. Of course, secondary prevention is screening, so early HIV testing, or getting everybody tested so they can get tested early. But this is even before that. This is primary prevention. So what is PrEP? It's a medicine that greatly reduces your chance of getting HIV from sex or injection drug use. It's for people who are not HIV positive, who may be exposed to people who are HIV positive. So let's think of some examples. Perhaps you have a person who's HIV positive and has a spouse, right? And so you would want to really recommend them getting PrEP to prevent them from getting HIV. Any other ideas of who might be at high risk or who might be good candidates for PrEP?
I mean, I imagine folks who are drug users. I don't
Yes,
know if that's
most definitely.
yeah.
Especially IV drug use, or not just IV drug use, because we know the drugs and the sex go together. So, you know, you have some IV drug users who are involved in sex for money or for
Mm,
drugs.
right.
Right, so they go together. That's why when we saw the monkeypox outbreak, you know, big problem in Montgomery because of the sex workers or the sex for exchange of drugs and or money. So all that goes together. So they would be excellent candidates for PrEP.
Okay.
Most insurance plans have them, and the state Medicaid programs, but of course our Medicaid program is not the best. But people have also worked with, and some of the clinics that do, PrEP engagement and follow-up have also worked with the companies that supply PrEP drugs. So of course, we know, it used to be pills every day, once a day. Now there are injections, even for PrEP, right? For HIV as well as PrEP, that are given every 2 months. So that helps with compliance, adherence. I'd like to use the word compliance rather than adherence. So that's what it is. And I have a video, and I think what I'm going to do, let me go back. Oops. Let me see if I can come out of this and
stop sharing your slides?
Yes, stop. I'll stop sharing. Let me go into my video. Oops. I was trying to share. Okay, it's not doing it. So what I'm going to do is I'm going to look at CDC, see if I can pull it up.
Okay, I was gonna say you can also drop it in the chat and we can try to share it if
Oh, okay.
it's giving you trouble.
Let's see if I can find it. Oops. CDC PrEP video. And maybe there's some questions while I'm trying to put this up. Any questions?
I don't see any in the chat right now.
Okay.
Oh, there was a question. When we
Mhm.
come back to your slides, maybe we can make them a bit bigger.
Okay.
It's not showing for us in presentation mode. So
Okay, I'm sorry.
that's okay.
Okay, let's see. Let's go to.
I want to make sure that I heard you correctly. You did say that PrEP is now given in the injection form, like
It is.
once every 2 months. Is that
Yes.
Oh wow. Okay.
Yeah,
I
which
don't
is
know if I
nice,
got that,
right?
Mm-hmm.
Which is nice. Okay, let's see if this is it. Can y'all see that?
Yes.
Okay. Can you hear it?
No.
PrEP, or pre-exposure prophylaxis,
Oh, yes.
is a medicine that can prevent HIV. PrEP is for people who are HIV negative and at risk of getting HIV. This includes people who have a sex partner with HIV, people who don't always use condoms, or people who have been diagnosed with an STD in the past 6 months. PrEP is also for people who are HIV negative and sharing needles or other drug injection equipment, or have a drug injecting partner with HIV. PrEP is highly effective for preventing HIV through sex or injection drug use. PrEP does not protect against other sexually transmitted diseases.
Oh, I'm sorry. Oh, I'm sorry. I was trying to fix my screen. Sorry.
Oh,
Try this again.
Only condoms can protect against STDs such as syphilis or gonorrhea. Visit your healthcare provider to see if PrEP is right for you. If you decide to take PrEP, you'll need to take it every day, or it's prescribed by your healthcare provider. For more information about PrEP, visit cdc.gov/HIV.
Okay, so you can see that the technology
Let's talk about that.
treatments have changed quickly.
Knowing all the HIV prevention options available to you to take control of your sexual.
Stop. Stop it. Okay, so let's get to my slides, right? Am I still sharing?
I don't see anything yet. Nope.
Okay, so let me share. Get to. Okay, so y'all aren't seeing my whole screen, or is it just a split?
So what I'm seeing is it's basically like your presenter mode.
Okay, let's see if I can get out of that.
Yeah, so it has like the next slide.
Okay, so let's see. See this. Is that? No.
Nope. No, we don't see
Nope.
anything. Well, we can still see the main slide that you're on with the graphic that's be safer with PrEP.
Yeah, but it's got that other slide there.
It
So let's
does.
see.
Yep.
Let's
Yeah.
try it again. Okay. It's still got that display. I don't know why.
So better than what we had before because it's bigger.
Yeah, I don't know why I can't get that off.
But yeah, I'm not sure.
Let's try. Let me try to end it one more time. End it. Let's try. Okay, now let's try it. Still got it in there. Ah,
Actually don't see it on our end right now.
really? Okay, so let me. Okay, I don't know why I'm seeing both, but anyway,
Yeah,
uh,
you can always send us the slides after.
I
We don't
sure
need,
can.
yeah,
I
we
sure
don't need them
can.
right now, but you can.
Yes. So,
There is a question in the chat.
sure.
I think the increased availability of PrEP has impacted the increase in rates of syphilis.
That's a great question because remember when they said when you use PrEP, you also have to use condoms for other STIs.
Right.
And that has always been a dilemma. I remember an ID doctor here, he didn't like the idea of PrEP because he thought that people would not use condoms. So the mess we have, but the onus is on us as providers and as educators. We've got to educate both the PrEP and the condom use, right? Right. That's on us.
Mm-hmm.
So that doesn't preclude, the PrEP does not preclude you using condoms because you still got syphilis out here and you've got other STIs out here. HIV is just one of many. If you ask me if you had a choice, you definitely don't want to have HIV.
Yeah.
Don't want to have HIV. So, and that's more sort of philosophy. What we should be really prescribing is everybody using all the tools available.
Mm-hmm.
So that's a great question though, because that may not be in the minds of some of our young people.
Right.
Because of course, some of them don't like to use condoms.
Right. Yeah, we try to always stress using dual methods.
Correct.
When we're teaching birth control option to prevent pregnancy plus
Yes.
barrier method.
STIs. Right.
And HIV.
Right. And you've got to fight against I hear kids say, I want to be bare. I don't want to feel anything. I mean, but we've got very, very thin latex. Of course, it has to be latex, right?
Right.
But they're pretty thin.
I think there's
They've gotten better. They've gotten much better.
Work to do.
Right. We do. In order to make the case for why they should. But great question. So dealing with the evidence, science, and the reality and the behaviors, good issues. So I looked up a couple of articles on why aren't the women, really doing the uptake. And I got an article, the first author here, she actually she used to work at CDC. She worked on my Project Faith, so I had to pull her article up. This was in 2018. She's now at, there's a small college in Decatur, Georgia. She works as a university professor there. Got the name of the college. But in her paper, we have to increase awareness about PrEP, particularly in women. We have to address the risk communication and assessment, why it's so important to have PrEP as a primary prevention tool, because you really don't want to have HIV. And we've got to address the patient-provider interactions. They talked about how it's so important for you as health educators with your organization, but also physicians, nurses, and others who are seeing the patients, pharmacists, whoever they are, to really have that trust and trusted relationship in order to really broker these conversations. Because that issue about distrust is real.
Yeah. How does that work in real time? Because I don't have many I'm not a healthcare provider, and I don't have many healthcare experiences outside of my own. I know for me personally, as a woman, nobody has ever talked to me about, in my whole, even when I was younger and unmarried, nobody was talking to me, maybe when I went in to get tested, but about condoms or any sort of preventative.
So that's a huge
Except
area.
for birth control, right?
That's
Except for birth
the,
control.
except for birth control, maybe a little bit during pregnancy. You talk a little bit about sexual activity.
I only did in term because I was pregnant, and I only did in terms of how to like because I had some concerns about preterm labor.
Right.
And so only in those terms, not in terms of protecting myself from STIs.
Correct. And
Yeah.
so more clinical, more clinical. The sex education piece gets totally left out.
Right.
And what the questions about what your sex behaviors are get left out, let
Right.
alone your sexual orientation. I mean,
Right.
you've got to know what people are doing in order to really help them. And then that is a whole area that is just still needs a lot more growth. And that's where your organization can really be helpful. I mean, medical students are sometimes talk about the sexual history or talk to the patient about the sexual history, but a lot of times it gets left out. And particularly, I think maybe the pediatricians might be a little better at it with adolescents, but sometimes it still gets left out. Very uncomfortable, especially when to do it, without the parent present, all those kinds of things. Because I think right now in Alabama, kids as young as 13 can request their own HIV test.
Yeah, I think with Medicaid, I think it's 12, but I think without Medicaid, it might be 14.
So, but we need to be having conversations about sexuality with these young people who might be getting tested, or the need to get tested.
Right.
So crucial areas there. In this paper, I'm not sure they addressed it per se from the sexual education standpoint more than, but if you're talking about PrEP, you've got to talk about people's sexual behaviors, correct?
Absolutely.
There's no way to get to it unless you do that. So
Right.
definitely, I'm glad you brought that up. Major issue. Because sometimes what happens is in the medical model that gets lost, right?
Right.
We've got to pull in the social behavioral pieces. So this map, and this, I'm so sorry it's so small, but if you just look at it, the darker the areas are is where our new HIV, where HIV is, more cases of HIV. And as you can see, we used to have large cases in San Francisco on the West Coast and New York City, East Coast. But now it's in the South and it's in rural areas. It's not just big cities. The South is really the epicenter. And this is for Blacks.
We can't actually see that map.
You can't see it.
Yeah, we can't see any of your slides right now. If you want to email them to one of us real quick, we could try to pull it up on our end.
And let me end this again and try it again.
Okay.
Okay.
But I do know that there is a whole push against, ending the HIV epidemic in the South specifically.
In the South specifically, because this is where the epicenter is now.
Right.
Because of course you've got large Black populations in the Deep South.
Right.
Yes. Can y'all see that?
I still don't see anything. Is anybody else seeing anything?
Can anybody else see?
I feel like I'm the only one, but I don't think we're seeing it.
What?
No, I can't see.
Oh my goodness.
Do you want to just send me the slides and I'll present them while you?
Okay. Let me do that now. Because I'm not, your slide kind of went away, so I don't know what's going on. But anyway, let me go into my emails. Megan?
Yep, that's who you want to send it to.
That's you. Any questions?
I don't have a question, but I did want to just kind of throw it out there. My name is Michael Workman. I work with STD surveillance with the state of West Virginia.
Mhm.
And I just kind of always poke in on different trainings where I might not have the most, knowledge. But John Hopkins, their training center is offering a 3-day STI overview.
Mhm.
It's later on this month, and it's geared towards. I'm just reading the flyer right now. It's
Mhm.
geared towards all healthcare providers that do not examine patients, like specifically, but they're going to
Mhm.
cover taking a sexual history, using like certain words and languages, and it'll be over their gonorrhea, chlamydia, mpox, syphilis, just a whole number of things, and
Okay.
it's got a lot of good information. I can put
Yes.
the registration link in the chat if anybody
That'd
would
Okay.
be
be interested
great.
in it.
Thank
That'd be
Okay,
you.
great.
yeah, great.
So I still got to find that Project Wise to send y'all. I just couldn't find
And
it
Dr.
quickly.
Foster, we can see your slides
I,
now.
s- I know. I
I don't know
know.
what
I
you
just,
just did.
you know what happened? It was on a different screen.
Oh, okay. Yep.
The whole
sense.
screen number 2.
Yep, that makes
Crazy
sense.
nonsense.
But
So
we can
let's
see
see.
now. We can
Okay,
see how the
good. Yeah.
epicenter is
Good. Yes. More in the South. You can see it's also like in what, Texas? Is that Texas? I don't know if that's New Mexico and some other
yeah, New Mexico,
southern. Yes.
South
Yes.
California.
Yes. Yes.
Imagining, and that's Arizona, so south,
Yes.
like by the
Yes.
border, which I'm imagining
Yes.
you have
But
more
look all up and down the East Coast and in the South.
Latinx population.
Yes.
And
Yes.
yeah.
So when I got here, I came from Tuskegee. I had come from New York City area, and I noticed right away, lots of advocacy around HIV in New York City, right?
Mm-hmm.
Atlanta, DC, where other places I've lived. When I got to Tuskegee, I was working at Tuskegee University, their bioethics center, absolutely silent. And I was like, what is going on? Even on awareness days, like World AIDS Day, quiet.
Mm-hmm.
So we started asking, and then there was more growing literature that talked about stigma being a reason why the epidemic was increasing in the South. This is the Bible Belt. So, we don't talk about sex education, not polite information. And also in the Black community. I mean, if I ask somebody, are you at risk for HIV? They said, no, I'm not white and I'm not gay. And I might even ask them, a male, I might say, well, did you have sex with someone last night? Another male last night? Yes, but I'm not gay.
Right.
So so stigmatizing. The label is stigmatizing. That's why we focus on the behaviors, men having sex with men.
Right.
But we asked 24 Black people living with AIDS in rural Alabama where they felt most stigmatized, and they said the church. And number one, it was coupled tightly with their disclosure. So we interviewed one lady. She said, no, I've never been stigmatized. We said, well, have you told anybody? No, I haven't told anybody. So very tightly coupled with who they tell.
Right.
But they were fearful of lack of confidentiality about the illness in church leaders.
Mm-hmm.
Because this quote here, I love this. If you want to keep a secret, don't tell anybody in the church, especially the leadership. They said, especially the pastor and the pastor's wife.
Oh, wow.
Horrible. Yes. So I saw that as an opportunity. Even though the church is the most stigmatized place, that's horrible. Should be one of the safest places that anybody can go. And the other reason why it was so important was, despite the stigmatization, spirituality was very important to most of the people living with HIV, not only for their, survival and living, but for their quality of life and for their healing.
But they weren't telling anyone.
Yeah. So we searched the literature, and then, we know the powerful role of Black churches in civil rights. My father's from Selma, Alabama, so I know this bridge well, Edmund Pettus Bridge. I have colleagues who are not from the United States. They culturally don't understand how Black churches work a little differently. And they're the cultural center for everything. Politics, everything, you name it. So we mix everything in the Black church. But I do want to mention, the reason I say civil rights is the NAACP has sort of rebranded HIV, and you might want to think about this even with sexual health. Instead of introducing it to pastors as a public health issue, we present it as a civil rights issue because the disparities are so great and even comparable to some other disparities. They have a whole poster where they show it's, similar to other disparities like health inequalities and prisons, inequalities in prisons, the prison, the education to prison pipeline. So, and even on that poster, they say if Black America were its own country, it'd be number 10 in HIV cases. So that sort of hits home to pastors in a different way, because sometimes they're a little uncomfortable with dealing with public health and science. And to put it in a language that they can really grasp onto, civil rights is one of them.
So interesting. Okay.
Yes, very interesting. I've written some other papers about it because really thinking about, even thinking about which pastors would be more likely to be involved with HIV, usually those who are involved politically, social activists. I don't know if I have that in here. Yeah, predictors here. Activism. Some of the denominations are very involved with HIV prevention right now, AME Church and some others where their bishops are saying, you must have education. So that helps. But I've got here some of the larger ones, they're getting support from higher up. The comfort of the pastor and the congregation around HIV and research, because I'm going to talk about HIV research with the congregations. Their own personal experiences with HIV, buy-in for the study by the pastor. I think I had in there activism as the first one, social justice, rights, health. But look at the last one. Occupation is also important. Most of the pastors were male. Their wives are nurses, which is a natural, lead in for doing health ministry kinds of things, right?
Yeah.
And then the last one is reverse migrators. I interviewed 8 pastors, and all of them were agreeable, right? We, as researchers, we sometimes say, and even with CBOs, nobody wants to tackle this issue. Oh, it's so hard. Nobody wants to really deal with it. It is challenging, but there are some people who do. Like I was interviewing the 8 people and I said, wait a minute, these 8 want to. What is it about these 8 that make them much more likely? And the majority of them were what we call reverse migrators. So, for example, my father left Selma in the 50s when he went to college. And when he graduated from Xavier University in New Orleans, all the classmates left the Deep South. They went to New York, they went to California, they went to Chicago. I was born in New York, but now all of them are coming back. Right. So these that I interviewed, they had grown up in Alabama, went away, and now they're back. But they're different than the ones who stayed.
Right.
So that's one thing you want to kind of look at as well. They have different experiences if they lived in New York City area or if they lived in Chicago, for example.
That's
so with this study, we were looking, I searched the literature to see if there was anything that, was decreasing stigma for individuals and community members. Because now what we're talking about is community stigma. Most of the literature was focused on internalized stigma within HIV, persons living with HIV. But this is different. This is community stigma. So what we wanted to do was increase HIV knowledge. First, we wanted to decrease stigma, HIV stigma in African-American churches, rural, Black churches. And then we wanted to increase HIV knowledge as well. So essentially, I did a clinical trial. I recruited 12 pastors. It took 1.5 years to recruit 12 pastors.
Oh my goodness.
To do research, because you're not just talking about just them doing the research, the whole congregation.
Okay. Yeah.
So that took talking to, the pastor, to the to the deacons, to the elders, trustees, everybody. Longer time. And for them to be comfortable with the whole, research protocol. So in other words, Christina, it takes time to develop relationships with who you want to develop,
Yeah, we know.
So you've got to.
Yes.
I mean, I've been in a relationship 10 years with some rural community-based organizations before I even asked them, let's do a project together.
Wow. Wow.
Of course, you want to go a little faster than that.
Right, right.
But I'm just saying it takes time to develop the relationship. There is a courting period. It's not just run in. Hi, how you doing? Let's do a project. But let me write the grant. You just get on it. Let me collect the data and bye. See you later. No.
Yeah.
Develop the relationship and continuing the relationship.
Yep.
Right.
Yep.
So that's half the lesson learned. 3 arms of a clinical trial. First arm using faith-based and anti-stigma messages around HIV education. We borrowed it from a church in Ghana, an organization in Ghana, because they were far ahead of us in this area, Christian Council of Ghana, and we adapted it to Alabama. Then we just did arm 2 was just a standard AIDS 101, and then arm 3 was our true control, where we just put HIV pamphlets around the church, and that was it. And we were hoping for a graded effect, and we did. We found, if you look on the left, 12 African-American rural churches. We recruited 20 from each, which should have been about 240, and it was around 199. We oversampled in some. The largest church was 200 people. We had to at least have 20, right, members in order to recruit 20. For example, I had 4 ministerial liaisons to help me with the pastors. So because pastors speak to pastors, right? It couldn't be me directly, especially as a female. And one of the ministerial liaisons, his church was so small, he only had 20, so he couldn't even be in the study, but he was one of our liaisons. We got 199, which was pretty good. We did good because we paid them. This was funded by Centers for Disease Control. It was part of a fellowship that I was doing. So you see here the 3 arms. The top arm was Project Faith, the basic HIV AIDS 101, and then there's just the brochure. And what we found was there was a graded effect. We measured both stigma and individual and congregational. So in other words, asking them, what would you do if you knew somebody was HIV positive? Would you sit next to them, at a bus stop, on a bus? Or if a person was HIV positive, would congregational members sit next to them if they were in church? So parallel sort of surveys. And we found that the Project Faith messages, curriculum decreased stigma more than the true control, the pamphlet, just the arm 3, and that the knowledge was increased both with Project Faith and with AIDS 101 compared to nothing. So great result. This is just some of our numbers, primary research hypothesis, and then secondary. We did a little statistical manipulation because the numbers 199 is somewhat small. But greater decrease for faith on individual level, stigma only, and then no difference between Project Faith and the AIDS 101, no statistical difference, individual or community. And then the knowledge was greater for both. Okay. And these are my ministerial liaisons. They're sitting at the table. I'm behind them with my research assistant next to me, my graduate research assistant behind her, and then Susan Gaskins is my research partner from nursing at that time. Okay, and this is everybody, CDC's team, large group. I had a lot of volunteers, student volunteers, but really a shout out to those ministerial liaisons because I could not have engaged the pastors without them. So something else to think about. I'm sure you do peer education and things like that. That really always is helpful. And I already talked about this. But the other good news is this is available. for anyone. You can download it from our website, Project Faith with 2 H's .ua.edu.
Right.
And we have, it has a table of contents. It tells you how long we had 8 modules. We added a 9th module because when we did it initially, no PrEP. So we added a PrEP module. It tells you how many facilitators you might need, how many, these are some of the sessions: AIDS 101, more understanding, less fear, advocacy for those living with HIV. I'm gonna tell you, we spent more time than we wanted to on the AIDS 101, so many myths that we had to debunk. And just, you could do a week on just AIDS 101 and debunking those myths, but we were trying to keep it to like 2 hours, I think.
Even with 2 hours, you
and-
felt like you needed more time.
Yes, most, because there's always more questions. Always. We got to do probably more and more of that. Just
and I
sex
think that,
education in general.
yeah, that speaks to a lack of sex education. We find
Yes, it does. It does. It does.
missing things in our implementations with young
Yes.
people is we're
Yes.
starting from a baseline that is not their baseline. Their baseline is much
Correct.
lower. Yeah.
Correct. Much lower. So that's something to consider. And the health literacy. I mean, even with the surveys, we had the surveys on tablets, but we also had to do assisted hearing, CASA assisted, because people can't read. A lot of people can't read. So, and then the last module, advocacy, I was really pushing for not only for them to decrease their stigma and know more about HIV. We wanted them to advocate for people living with HIV, you know, both politics, policies, advocacy days, churches doing more support groups, and that has been slower than I would have liked. It just, people are just not there, and they probably need more skill sets and workshops to help them develop those skills. So that's an area that's unmet. But we have been able to see all these different organizations that have used the curriculum. There are 2 in North Carolina now. I can add Duke University. There's a program that's using it. And yesterday there was a graduation for Amen to Action, a group that used the curriculum. So just really proud that we've been able to share this with so many others. And hopefully you'll be able to take a look at it as well.
Yes.
And did I didn't put it in here. I have a radio show.
I want to hear more about that.
It is funded by the EHE, Alabama Department of Alabama Department of Public Health, ending the HIV epidemic. It is called A Woman's Worth. It is on me and my husband's. We have a nonprofit and we have a community radio station in Montgomery.
Okay.
So I'm going to put it's 94.5 FM.
Okay.
I'm going to put it here, 94.5 FM WUMO. And you can also get it online.
Okay.
WUMO LP lowpowerfm.org. And we do the show Monday, Wednesdays, and Fridays, 12 noon, 6 and 9 p.m. And then on the weekends, there's a schedule, Saturday, 10 p.m. and Sunday, 1 p.m. So check us out, 30-minute show. This is a way for us to try to disseminate more information and get information out. We're getting picked up by Pacifica Radio.
Okay.
To go national. So we have a Facebook page, A Woman's Worth Health and Wellness, and we also have our website, awomansworth.info, where we would love if you listen to a show to fill out a survey for us so we can have evaluation of the program. So I just wanted to mention that. I thought I had put a flyer in, but
we will share all these resources.
Okay.
With our list that's registered, and we'll share these slides too. If you'll
Okay.
share with us.
And then I'm going to see if I can find that Project Wise. I'm looking for it now.
Yes, that would be great too. We will.
So
share that.
any questions while I'm doing that in between? I'd love to answer.
I feel like maybe there was one question. Oh no, I already read it to you. A couple
Okay.
folks have shared good resources. We will share those out as well.
Mhm.
We are at our time, so I just want to point everyone to the
Cynthia, I'll call you back.
evaluation that is in the chat that Megan has dropped in the chat. You will take a moment and fill that out after you get off the call today. That would be very helpful.
Okay, and I'm still looking for the WISE
And
report.
that's okay. You can send it to me after, me or Megan after, and we'll
Okay.
disseminate it.
Yeah, but you know, if I don't look for it now, it ain't happening.
I hear ya. I feel that way too. Yeah. Okay. Well,
Okay,
thank
so yeah.
you so much for being here with us
Thank
today.
you.
This has been great, and it
Yes,
looks like folks in the chat are saying the same.
fantastic.
And we hopefully will be able to have you back at another time.
That would be great. Yeah, maybe I can talk about it. The report was called "It Takes a Village."